Akila madam? No, you log out. YouTube. Akila madam?
Yeah, ಕೇಳಿಸ್ತದೆ.
Raju sir?
Sir, ಹೇಳಿ.
Shall we start?
ನಂದು
Yes, sir.
ವಿಡಿಯೋ ಆನ್ ಆಗ್ತಿಲ್ಲ ಡಾಕ್ಟರ್ ರಾಜೇಂದ್ರ.
I'll make you host, madam. Huh? After that, you make Raju Giraddi host. Huh?
Okay.
Yes, madam, your host now. You can start.
So you can hear me, Anna? You can hear me?
Yes, madam.
Good evening, everybody, and welcome you all on behalf of Karnataka Institute of Fetal Sciences to yet another wonderful topic for today's discussion, diagnosis of Mullerian anomalies on 2D and 3D by Dr. Raju Giraddi. Dr. Raju Giraddi works as associate consultant at Bettadur Hospital, Raichur, and I'm sure many of you must have heard him before. If you have heard him, you all know his wonderful images and also so many intra-op correlative findings which he gives. He has been a speaker in many multiple CMEs and conferences, as well as he has published multiple papers and in fact has won many prizes for his presentation. So it's an honor that we have him here today as a speaker, and I'm sure we'll all benefit from his talk today. So welcome you, Dr. Raju sir, and
Thank
a
you.
very warm welcome to all the delegates.
I'm not able to see my.
Sir, I'll make you the host now.
Yes, ma'am.
Just give me a second.
Thank you, ma'am. Thank you so much. Thank you, Akila, ma'am. Can I share my screen? Is the screen seen, sir? I need some response from anybody. Is my screen shared screen is seen? Hello, ma'am. Hello. I'm not able to hear from anybody. Screen share, sir. Sir. Okay. Okay. One minute, sir. Mean, sir? Togori, sir, please.
Raju sir, you can start sharing your screen. Huh? You are host now. Raju sir?
Yes, sir. Yes, sir. Yes, sir. Thank you. Hello,
Yeah, you are
can you hear
audible.
me?
Yes, yes.
Yes. I will
You are
share my
audible.
screens.
Yeah,
Yes.
please.
sir.
Sir, is it seen, sir, now? Hello, sir.
Yeah. Screen is in. You go to full screen.
Yes.
Presentation.
Yeah, it is seen now, sir, full screen.
Yeah. Perfectly seen. Go ahead, please.
I very good evening to one and all. Thank you, Raghavendra sir, for giving me this wonderful opportunity. I thank Karnataka Institute of Vital Sciences, the team as well, and all the members who have taken this part today for and joining to listen to this. I'm very happy to be part of this, and I should really thank Raghavendra sir for making this happen. So basically, I am getting into your fetal medicine compartment, but still I want to take on those entities where does this matter for our fertility purposes. So we all know that most of the Mullerian anomalies are diagnosed most of the times on 3D. So we shall see that some of us may not be so good in 3D, but definitely we all are doing our 2Ds. So what in 2D are the hints? What in 2D are the diagnoses that we can make? Where is it necessary to go for 3D? 3D may not be necessary in all the cases. So that is what I want to stress upon today. And I'm very glad that most of you all have participated in the 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 polls that I had put on the majority of the clips that I'm going to play today. So I'm very happy that most of you have got it correct. So this I want to make a disclosure here. This is our part where I have taken only one photo from the internet. Rest all is our clips. And most of you have listened to this way back in maybe in Kasoga, in some other platform, but it's going to be a repetition. Yes. So, as we all know, I'm not going to put any literature regarding the incidents, the embryology, nothing, because I want to straight away go into how we are doing scans and what is that you are looking into scans and how we are going to diagnose the things. So, if you ask me the word hysteroscope, okay, the hysteroscope tries to look into the uterus, but it is a misnomer where we try to look into the vagina from the introitus. We start seeing that. In the same way, transvaginal sonography has to be done from the introitus, not putting your probe in the anterior or the posterior fornix and then looking at the uterus. So why am I stressing on more on TVS is because these Mullerian anomalies most often we are encountering, especially for the subfertility cases or the infertility cases that we have in present population. And no doubt that we are screening them with our 2D and 3D for the Mullerian anomalies. We may get Mullerian anomalies with complaints in an adolescent or an unmarried girl. In that case, we may do a TAS. There is no other go. But if unless proved for infertility purpose, TVS is the answer. So this is how I do my transvaginal sonography. I begin from the introitus. I look at the 1 second. I'm very sorry. So this is the bladder and the urethra here. I try to place my probe slowly into the anterior fornix. So I have moved from the introitus to the anterior fornix. I keep my sector width at 180 degrees. And as I place my probe in the anterior fornix, I know this uterus is being antiverted and antiflex. I play with these focal zones. This focal zone is very important. And also I enlarge the image, take the depth so that the region of interest is covering almost 80% of the screen. As I'm trying to look here into the cervix on the anterior and the posterior lips, I look along the endocervical canal and into the endometrial lining. So now I adjust my focal zones and depth, and then start comparing. Now I move my probe towards the right side of the screen or the right of the patient. Then I come back to the middle, and then I go to the left of the patient, the left of the uterus. So this is my sagittal sweep. This is my first sweep where you can analyze that it is compared with the anterior myometrial echo with the rest of the endometrial echoes and all. So for today's class, this transfer sweep is very important. I do it this transfer sweep has to be anti-clockwise because my logo is under the right side of the screen. Here I'm trying to assess the endometrial lining in proper. I go towards the cervix. I go towards the cervix where you can see there some few nebothens here. Then yes, I have reached the cervix. So again, I come back from the below and I come up here. What I'm trying to look here is look at the endometrial lining, whether it is in continuity as a tubular fashion or whether it is getting split across. So this is how I try to analyze the uterus. One thing we need to understand is that your span should be sag as well as your transverse throughout the entirety, such that you lose the uterus in one end, then you come back to the middle, and then you go to the other side. For today's class, this is the important thing where I'm going to show you, because I am not going to the adnexa, because most of the Mullerian anomalies which are related to the uterus and its pathology are into the middle compartment. So I have not taken those clips. So we'll begin the first case. I want you all of you to analyze this. I'm very sorry, this is getting slow. Okay, this case I want you to analyze. Here it is in my SAT sweep. I'm coming towards right side of the patient, then I come back to the middle, then I go back. This is the middle of the uterus. Then I go back to the left side. This is my SAT sweep. What is that you are able to see in comparison to the previous clip? In my SAT sweep, I was able to see that I'll try to show that again, but this is a transverse sweep that is more important. Here in the transverse sweep, you are able to appreciate two bifid endometrial canals or the endometrial echoes, which are got bifurcated. So, and you can see in between myometrial tissue there. As I go towards the middle of the corpus, they're getting united, and I go towards the cervix. It's a uniform endocervical canal. As I come towards the fundus, they are getting split. So what is that I'm trying to tell in this case is, if you look here at these two bookmarks, okay, I'm sorry. One thing I want to tell you, as I come, yeah. So when I'm in my mid-sag, when I'm in my mid-sag, this endometrial lining is stopping abruptly far away from the serosal lining. In the sagittal sweep, here if you can see, the serosal counter here is maintaining its integrity as the convex structure here. And you can see a lot of myometrial echoes in between. The endometrium is stopping here at the middle. But as I play across, when I take my transverse sweep, it is towards the right, it is going to one cornu, then it comes back to the middle, then it goes to the other cornu. Here is a definitive hint in this ad sweep itself that it is a Mullerian anomalous uterus. This is a very important sweep, but all of us, we keep looking at the endometrial lining. That is not important for me. I want you to look at the serosal lining of this uterine borders. Look here, this serosal lining is maintaining its integrity as a convex structure. Even when I go up to the fundus, even when I come back to the fundus, okay, I'm coming to the fundus, this integrity is still maintaining even when the bifids endometrial lining are losing their echoes. This means that this is a case of septate uterus. What it would have been if it is a case of bicornuate. Here you would see dimple at this and this serosal lining. So that is more important. We should keep looking at this serosal lining, whether it is getting dipped or it is getting bifurcated. In that case, you would see the echoes of the omentum or the bowel sometimes in between the bifid endometrial echoes. So that is more important. So I know in 2D, this is definitely a case of subseptate uterus. So this is what. So in subseptate uterus, we know what is more important is that we need to look at this serosal lining. We only concentrate in most of our 3D images. When somebody gives a 3D image, we only look at these horns getting bifurcated and we think it is a bicornuate uterus. We need to look at this serosal lining. That was the mistake in the first image which I showed today. I didn't show you the serosal lining, but nobody commented on that. I know it is subseptate uterus, it's easy, but you should have asked me, this image is not complete. So you need to ask for this serosal lining in a 3D where you will be able to assess, okay, this serosal lining is maintaining its integrity. So the horns are well within this uterine cavity. There is no dimple here. It's a case of subseptate uterus. So that is what this was my first question, but many of you have got it right, but that was not the answer. I wanted somebody to say that your image was incomplete to define that. You can have a septate uterus. Why am I taking septate uterus as the most common to begin with? Because the first and most common cause for your fertility issues with respect to recurrent pregnancy loss or infertility or preterm delivery, the first cause is septate, the second cause is septate, the third cause is still septate. Bicornuate uteruses are very rare. It is only on the radiologist or we as sonologists, we keep diagnosing those things. They are more common on papers rather than on the patients. So you can assess these are all subseptate uterus. But what about the serosal lining? This can be a uniform one. It can be a convex one. You can have a dimple like this, but this dimple should be less than 1 centimeter. It is still a subseptate uterus. So I want you to analyze this case important because this is the raw image. I want to make it very clear. Magic cuts only to define and beautify the images, but that do not play a very important role. But these are the images which will play a very important role. So the raw image what you get in 3D. So look at this image. You have a very bifid and widely angled bifid endocervical endometrial linings. But look at the serosal lining. This is very important to define. Okay, they are well, these two horns are well within this house. Okay, now look at the angle. Look at the angle. This angle is almost reaching up to 130 degrees. So it is no more like you don't depend on the angle anymore. You need to define how is it. One horn may be in Ballari today, one horn may be in Raichur, but if it is in well within this cavitator lesion, yes, it is a septate uterus. Don't ever depend on the angles and just quantify your images based on angles. It is looking more than 90 degree. It is bicornate. No, that is not the answer. So you can have very thin septa like this at times, but that is very easy and obvious to diagnose such things of septate uterus. So we shall look into. So what is that we need when you put yourself on? Better is always it looks good that you put yourself in diagrams. Nobody will read what all you have written, blah 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 and all. Maybe whatever classifications you want to follow, you can follow. I follow X-ray because I like it. So you put it in your diagram such that the surgeon, the endoscopy surgeon, will come to know, okay, how broad is the septum and what kind of counter it is having. So these things will give them more important information than what we do. This is a case of small septate uterus. Why? Because if you say a septate uterus, you are not complete. You should say a small subseptate uterus. It is so and so dimensions. And these cases can be done with your simple hysteroscopic seizures. This is my doctor, my boss, Dr. Jayaprakash Patil sir, because of whom I am today here presenting these cases. It's all his surgeries. And what I have learned most on Mullerian anomalies is retrospective learning, and it's all because of him. I am very grateful to him. So you can see that was a small subseptate uterus. You have another septate uterus which is reaching up to the lower corpus here. This is the right horn. This is the left horn. So we will accordingly, the surgeon will plan his surgery, whether I need to go with the scissor or if it is a thick septa or he will be using a resectoscope like this. It depends on the choice also. The person's caliber who does such things. He can also do this with your scissors as well. So that is the importance. Now you can see here in this case, you have a small RPOC in that. You have the right cavitatory canal. This is the chronic RPOC that you have. You have a very thin septa here. You have very thin septa. This is the left ostia. So why is it so important to give us? Because such thin septa of late we are often cutting with our hysteroscope in an office hysteroscope as well. That is we are doing it without anesthesia. Why am I telling that we don't need laparoscopy here? When your imaging is good enough to say that it is not a bicornate uterus, yes, office hysteroscopy for such small septa is enough. And I showed you RPOC. So I think the tubes will definitely be open because fertility is not an issue in such cases. So I put this image. I'm glad that many got it right, but most of them got it wrong. So I want to tell you this is not the image what you people are thinking. Some of you have told it as unicornate uterus. Well, the answer is not unicornate. Why? Because we don't do HSG in our unit, but only when somebody sends as a referral that because we do HSGs here. It was long back, but still we have that unit. So when somebody sends for HSG, we do the HSG, and this is what we did here. It was a referral. So do you think I will send the patient with the reporting here? We cannot. Why? Because I subjected her for 3D, and this is what I get in 3D. The same patient, the same image. So that was in HSG. Now it is in 3D. What went wrong in this case? See what has happened. There was a single external opening, but my leech Wilkinson cannula entered into one of the uterine horns, so I could image only one. So if it would have been a case of didelphys uterus, definitely when I would have put a speculum, I would have seen two bifid cervix. Okay, then I would have imaged one and another here. This was a case of complete septate uterus, which was the septum was beginning well just inside the inside this cervical canal, I would like to show you that 3D is not always single coronal plane. 3D has to be, sometimes we need to go lower down to define your cervical lesions or cervical anomalies. You can take concentrating on the lower aspect. Here you can see, here is the single external. I can show you in better part here. Yeah. Here you have a single external os, but you have one cavitated lesion which is beginning here and another here. The cervical septa is beginning just above the external os. So it was a complete septate uterus. So my leech Wilkinson cannula, though I was seeing single external os, it entered into one of the horns up till here. So we could image only this part. So 3D is actually, I don't say it is always a static thing. We need to play with those with your knobs, like what you call it as walkthrough. And it is also a virtual or real-time imaging that is not always 2D. 3D also helps in such things. So the same case when we did a hysteroscope, this is a single external os. Okay, this was operated in our one of the conferences. The same case. So this is a single external os. We went inside with the hysteroscope, and this is what you see. I want you to analyze this because these things we often make mistakes. Okay, I'm very sorry. So this was into the right side of the uterine cavity, cervical canal. So this is the septa. This is the septa. Just as we entered the external os, this was the septa that was beginning from these are cervical crypts, what you can appreciate there. So this was the right side and this was the left side. So you can see these two cavities were leading onto the uterine corpus as well. So this was all about our Leach Wilkinson cannula surpassed the cervical septa onto the one horn that was on the right side. This is the left side and that was the right side. So we went ahead with resectoscope and we did the resection. And this was the case. Why is it important? I'll try to tell you. So if you look here, this case of 3D is showing us two well-defined cervical canals. They are separate wide apart. So when I go down and do my 3D, you can appreciate that there are two good cervical canals. So you can use this this imaging also to say there are two well bifid cervical cervices. The importance here is that you have a circular muscle which is there separate for each of the cervical cervical external os. So you find a thick septa here. There by the surgeon's rule, some of them they don't want to cut the septa in between in such cases of complete septate with a bifid cervix. Whereas the first case, which I showed the video as well as the whereas the HSG, in that case, since the septa was beginning well from the cervical canal, you could cut that septa. But in such cases, we are not cutting the septa. We are leaving the septa. Only the internal part from this above the cervical canal, the corpus part is cut so that we want a wider cavity for good uterine volume for pregnancy to hold on. So there are two schools of thought in that. They can have endoscopies usually have a debate. What if I cut this? If they cut this, definitely they want to put a cervical stitch. So if I ask tomorrow that based on HSG, do you want to classify this as septate or a bicornate? I don't think so. You will be doing it henceforth. So yet another, okay, when I was trying to span across this lady, you can see, I could see a very good corpus on the uterine cavity, corpus and the cervix on one side. I moved my approach towards the middle and I went towards onto the right side, onto the left side. I couldn't find the other, a lateral part, but I could see a well-defined another uterine horn as well as the separate cervix onto the left. So this was clear indicative in my 2D itself that I was able to see two well-defined uterine cavities with two well-defined cervical canals of the same. So this is very clear. This is very clear that you will never miss this. You will never miss this when you are doing your 2D imaging itself. We know there are two well-defined uterine cavities with their corresponding cervices. Then you know it is a case of bicornate or whatever you want to use the terminology, bicorporeal, bicolous, or what you can use it as didelphys. So yes, I want to put it again. These didelphys uteruses are very rare. Bicornate uteruses are very rare. Septate is the most common entity. 3D is difficult in such cases, but you can do it by using your transabdominal probe and decreasing lot of depth. You might get the image. So here again, I want to show yet another. Sorry. So in this case, when you get two bifid cervix, now it is not a complete examination. That is why I like Ishreya more, because they put the uterus, the cervix, and the vagina separate. We as a transvaginal sonographer, we will be able to appreciate the cervical canals. But when you need to look at, we also need to look, maybe we have to look into the speculum examination to look for the septa of the vaginal septa as well. What will happen? What would happen in my case? When both the corpuses are communicating to the external world of the vagina, I would place my probe into one of the vaginal fornix. So this will definitely collapse. Then definitely I would be imaging only the both the cervix and both the uterine horns. So I will not be able to sometimes image this vaginal septa provided you use some gel sonography or something like that. Or if there is a non-communicating horn, suppose you have a ovira sonography, which I don't have. If you have a non-communicating vaginal septa, which is having a hematocolpos here with associated renal abnormalities or renal absence, you will be able to diagnose a case of vaginal septa as well. But in such cases, when it is intact with the external world, so you will usually miss this longitudinal vaginal septa. So what is my take is, whenever you get a bicorporate or complete septate or complete septate or didelphys or bicornuate bicollis, always look for vaginal septa as well. That will give you a more definitive diagnosis with your imaging perspective. Yet another case, if you want to see, there are two uterine horns well separated. See, they are not maintaining the integrity of the uterine, the serosal counter. There is a dip here. This cervical lining is going wide apart. This is going wide apart. You are able to see the echoes of the bowel in between them, and you have a single cervix. It's a case of bicorporeal unicollis uterus. So this is how we need to define such things. So this was the intra finding of the didelphys uterus. There is no role of unification surgery now in the present era. You just have to see how they are communicated. And now I only look for the tubal test and come out, the patency of the tubes and come out. So you have, okay. Another case. I wanted to, that is the importance of putting, if this case was put for today's examination where there was a dip here, this would have definitely come in my photo screen or today, the first image which I put. You can see a dimple, good dimple here in the serosal counter. So what is told is, if you join the serosal borders on one side to the other side, and if this depth is more than 1 centimeter, if it is more than 1 centimeter, this it will go into bicorporeal entity. This will go into bicorporeal entity. Then what about this? Still the bifid endometrial cavities have tissue in between. This is septate entity. So it is a mixed entity of a bicorporeal septate entity. So this is there. This was there first time given by the Eshrei people. Now ASRM also has come up with this. So definitely we have an answer for that. Now this case is the only image that I've taken from the net. Here you can appreciate this has a very good dimple in the fundus, but you have a very good septa in between these two horns. Why this imaging is important is that once you have drawn this on your paper with the image, the surgeon comes to know that I should not overshoot. So I know I have to be careful that he might definitely cut enough to unify the lower part, but definitely you should be cautious that he should not overshoot. So bicorporeal septate entities are also common, sometimes missed. We cannot call this as only bicorporeal. In this case, when the depth is less than 1 centimeter, this is less than 1 centimeter. So it is a case of septate uterus. This was the image that I would put in the third slide. Okay, so tomorrow, once you start doing your scans and you try to see such cases, and morning when you see there are the separation of the uterine horns, sorry, the endometrial cavities at the fundus, then what is this? When I do a 3D, now here the confusion comes. What is this? For most of you who have got the diagnosis, it is arcuate variety. Now I want to stress upon, but what happens to this entity? So it has more deeper indentation depth of the uterine horns. So we'll go ahead with the classifications. We all know about the X-ray and the ASRM. ASRM now has got updated in 2021. I want to bring in something called as CUME, that is congenital uterine malformation by experts. There's someone called Ludwin and his group are doing some very good work in septate entity as well as the T-shaped entity. So if you go by X-ray, I want to make this very clear here. This is the endometrial cavity. This is the myometrium. This is a line, imaginary line joining the two corneal lines, and this is the serosal lining. So what they want to call this as the wall thickness, that is wall thickness, and this as the indentation depth, that is from the midpoint of this imaginary line. What Ishray wants to tell is, if the wall thickness is suppose 1 centimeter, And if the indentation depth is 6 mm, they're not taking 1 centimeter, okay? It is proportion. They want to bring proportions for that particular uterus. If it is 1 centimeter, this has to be more than 5 mm. If it is 6 mm, then they call it as septate uterus. For example, if you go to ESHRE 2021, now they have realized their mistake. Now they have kept it as 1.0. Okay. So now depth of more than 1 centimeter, but still they have kept this angle as 90 degree. I have shown in one of my diagram, it was more than 120 degree. So yes, that is what they are lacking now, even after 2021 update. We do have a lot of, I don't say there is a uniform criteria for all these things. That is why they fight with, even in obstetrics, we have the ACOG and RCOG. Even in endoscopy, they have the American and the European. So here they though have kept it as 90 degree, but still we know there are many septate entities with a wide waist horns. So, okay, they have kept this as fixed, they pitfalls on both of them, and they try to simplify, but this is what they have made. They have made angle, they have increased the angle to almost 140 degree, angle to 140. Okay, my first image was falling well within that. Depth, they have kept it as 1 centimeter. ASRM changed after QM's 2018 criteria. They have kept, now they have come back to 10 now. And this is the important criteria they are telling, that is indentation to wall thickness. So they are telling the preferred criteria, simplest and most reliable of the three, is the indentation to wall thickness ratio. What is that telling is, if the indentation wall thickness is 1 centimeter, the indentation depth should be 1.1 or 11 mm. So yes, by ESHRE, they say that you are over-diagnosing septate uterus. By ASRM, you might be under-diagnosing. Yes, still there is fight between on. I'll keep it to the whatever classifications you want to follow, and put that my classification, my answer to this subseptate or septate entity. Maybe it is subseptate only, because septate nobody will make any problem. Subseptate entity is because of this. I am following the ESHRE. Based on this ESHRE, it is so and so. You can put it on your papers. So it depends. Now it is left to the surgeon to decide what it is, because we do have separate hysteroscopic guidelines for that. Now what I was trying to tell you is, now arcuate is nothing. It's now normal. Arcuate is now normal. Now nothing called as arcuate. ASRM has removed arcuate. So yes, this is a case of arcuate uterus. You can see the third part. The indentation depth is less than 1 centimeter. So it is arcuate. I don't want to confuse you putting these papers of the classification, because it is practically not possible for everybody to remember these. So this is an era of your, whatever you can call it as AI or what, it's an era of your phone. What is more important for us is how good you are in doing your 2D scans. Once you got a hint there, you go for the 3D and compare those imagings with what you have, this charts. You open up your phone with any of the classification like the ESHRE or the ASRM, and try to compare that. I see ESHRE puts uterus entity as separate, and most importantly, they are classifying the T-shaped, infantile and others, whereas others are not talking about it, especially the ASRM people. QM is good enough to tell about it. They want to put cervix as a separate entity, vagina as a separate entity, and ultimately they want us to draw the diagram what you have done. So they have put a space for that. So now ESHRE is way back in 2016. I think they need to update now. They will come up with the corrections they have. ASRM, which was a recent one, definitely we can't remember all these things. Yes, they are now bringing out the combined entity. They have Roberts entity. They have the Uvira. It's very not practical for all of us to remember. You can download these papers. They are easily available and read. And also, I want you to read Critical Review on ASRM by Ludwin. They want to bring out the pitfalls what the ASRM has got. So this was the case I posted. Not this case. In this case, I'm trying to show you. When I was going towards the right side, I was able to see the endometrium was reaching to the right corner. When I come back to the middle, and go towards the left, I was not able to find this endometrial lining. I abruptly lost the endometrial lining as I went towards the left side. So what is that happening in this case? So I was able to get the endometrial lining is getting moving. It is moved towards one side. It is getting moved towards one side. That is onto the left side. I'm not able to find a triangular shaped splaying of the endometrial lining in my transverse sweep as well. It is being tubular, but it is going to one side. I hope you all got the diagnosis. See, this what will happen in such cases, usually you will maneuver a lot. The uterus is deviated to one side, and you try to figure out the endometrial lining is only towards that side. And usually the ovary of that particular side where the endometrium lining is going, that ovary is near to that, whereas the other ovary appears to be detached and is far away. So I am talking about unicornate uterus. The hint to unicornate uterus in our 2D is that you will not get the uterus in your proper mid-sag. You will have to maneuver a lot so that you will try to face, okay, whether it is deviated to right or left. There are few conditions where a uterus can get deviated. One is a Mullerian anomaly like this, which is actually rare. Other would be a adnexal pathology, sometimes because of previous cesarean as well. And usually the adnexal pathology as well as the other abnormal uterine pathology like the endometriosis associated with the question mark shaped uterus. Other things, yes, usually the uterus will be in mid position. So this was the clip that I played today. Try to understand here. I am trying to show you something. There are two uterine cavities that you are trying to see. There are two uterine horns you are trying to see in the transverse plane. But this was on the left side, which was communicating the cervix, whereas this was on the right side. This right side is not communicating. So you have collection here within. This is a functional endometrial lining. You have a collection within. So it was a case of unicornate uterus with the right rudimentary horn. So you have a right rudimentary horn, but which is non-communicating, whereas this was a left. This was a left communicating uterine horn. So you can call this as a left unicornate uterus with a right non-communicating uterine horn. So usually such cases when you diagnose are usually associated with endometriomas on the either side or endometriosis on the same side where there is a block. So we can play one of such videos of that case. So you are able to appreciate that in the hysteroscope that hysteroscopic view is leading to only one cavitatory endometrial horn, one ostia is seen, whereas the other side it is not seen. So we got the diagnosis. It is a case of remove this pen. So you can appreciate on the right side, there was a non-communicating rudimentary horn and associated endometriosis. This was a left communicating unicornate uterus. So this was today's case.
Hello. A case for analysis. She is a case of secondary infertility where she had two early or first trimester miscarriages, and now is in an analysis where I am trying to sweep in the TVS, where now I am in the transverse plane at the level of fundus. Don't worry of the splitting of the small endometrial linings at the level of fundus. It's just a normal split. And what about this? And I'm trying to show you in the transverse plane as well as in the sag plane. This is another sweep to show that in the sag plane she is on day 8 of her menstrual cycle, and then I go to the left side, I come back to the middle, then I take the transverse sweep, I come to the fundus, I come at the level of the fundus, then I go to the level of the cervix. So I hope you got this clip and try to analyze what is this. I have measured some measurement here. This can be a clue for your diagnosis.
I'm glad that many have answered that we need 3D for this, but I don't know. So I thought somebody would tell the answer. Many of them knew this because I've shared it in various groups. So here you look as if you're looking into normal uterine morphology where my sweeps are onto the sag as well as the transverse. But when I do 3D for such a case, this is what you get.
The same case in 3D, this is what you get. I need not tell the diagnosis now, it is clear-cut evident that this case on 3D rendering shows this cavity. So now I'm able to go with the Kuhn criteria to diagnose this case, where I will be measuring the cornual angle, the lateral cornual angle, and also the lateral indentation angle. Now if you can see here, this measurement ideally it should be less than 40, and it is reaching up to 41 degrees here. So now the lateral indentation angle is measuring around 125, that it fits, that is it should be below 130. And now you have the imaginary line from one cornu to the isthmic region. When you take this and from the lateral indentation
We should not include the
point
cervix.
to this
We should not
perpendicular,
include the cervix.
the line of the imaginary line, if this measures more than 7 mm, 7 mm, then it is a good lateral wall thickness. So it's a case whether we need to analyze that all cases of infertility need to be defined as a case of this is a lateral wall thickness we measure. So whether 3D is necessary for all infertility cases. Thank you.
Yeah. So such cases where you do hysteroscope, that we have our own hysteroscopic criteria to diagnose T-shaped uterus as well, where you don't see the ostia in one go, where they are deeply seated and it is tubular cavity. Then we have the diagnosis at T-shaped or the cavity. First, we have to rule tuberculosis in such cases. When you have ruled out tuberculosis, we see that the lateral walls are having concentric rings and the myometrial wall thickness is more. So that is when we go ahead with the hysteroscope and the resectoscopes, and we cut those. So you can use either scissors or the resectoscope for widening the cavity, as what we call it as metroplasty. So such cases, definitely these are the small concentric rings on the lateral wall aspect. So we need to widen this cavity because we have given the lateral wall thickness as more than 15 mm. If it is so, and you have defined that well, this will help the surgeon only after when you have done a good 3D and you have told the myometrial wall thickness is good. So that was with scissors. You can also, this is another case of T-shaped uterus where you can go with that. So here is another case. It was normal as we spanned across. So, but this is what we get in 3D. This is a case of T-shaped uterus. So there is another criteria for that. I will be sharing that again video in another format. This is the Cume criteria. I'm not getting how to get the pen. Okay, we'll move to the criteria of Cume. So Cume wants to tell us if the lateral indentation angle is less than one, if it has to be less than 130, and this corner, this imaginary line from one cornu to the isthmic region is to, you should not include the cervix. It should be this depth where you have a perpendicular line drawn from this angle. It should be more than 7 mm, and this T angle should be less than 40. If it is fulfilling all these criteria, it is called a Cume T-shaped uterus. And if it is fulfilling half of that, you can call it as partial. Till so this was a case that we operated, and we did lateral metroplasty on the same case with using energy source. So still you are not able to see the ostia. So we had to give more cuts to analyze these things. Okay, now we are able to see the ostia. So it was repeated on that side also. So we do this metroplasty to widen the cavity. So this is how it looked after we have done the metroplasty. And such cases are usually associated with cervical insufficiency as well. So we do cervical encerclage after they conceive. Most of them get the Shirodka stitch, and she recently delivered this patient. We usually put the cervical stitch. Sometimes we do it interval lap stitches also. That is called Benson and Durfee stitch, which we do it by a laparotomy. So the same way can be replicated in laparoscopy as well. So this is very obvious. This is very obvious to say that it is a T-shaped uterus. Such uterine cavities has to be ruled out with hysteroscope and do a good hysteroscope to rule out tuberculosis in such cases. So now we have few more about subtypes of T-shape. Now you have anybody can tell me what is this? I have shared in some of the groups. This is an I shape. This is a Y shape. This looks subseptate uterus, but it is not subseptate because the cavity is tubular. So this is what we have as T, I, and Y. These are the subtypes of T-shaped uterus. You can watch this video. It is very good in this in the Fertility and Sterility Journal. You can watch this in YouTube. So what is important here? We need to understand before putting it as T-shaped uterus. If you look here, the morphology of the endometrial lining in this uterus is appearing T-shaped, but this is not T-shaped uterus. It is an infantile uterus. What the author says is if the sagittal length of the uterus is less than 6.5, this is what the international people say. But for us, maybe we have seen many ladies having less than 6.6 centimeters also, they have delivered 2 or 3 children. But maybe you have to have a cutoff like 5.5 or 6. And if the corpus to cervical ratio is 1:1, then you put it as infantile. And if it is less than again 5.5 or 6 centimeter, if the corpus to cervical ratio is 2:1, you call it as hypoplastic. You cannot though you do a 3D and get a T-shaped morphology, in such patients, you should be careful that you should not be doing correction. Here you can see I have a very small uterus, uterine bud. This is 1 centimeter. It is a case of infantile uterus. And what about this? This look normal. But if you look here, the total length of the uterus is measuring around 5.1 centimeter. So definitely this is not a case for our correction by surgery. When I do 3D, you might get a T-shaped morphology in this case. So we have to put them after ruling out your other possibilities of COX and all. You have to rule out, put them on hormonal supplements. This was the case I posted today. I will play this again. I'm glad that only one. I'm not sorry. Only Sushma madam got this right because nice. This is a case of. I'll just show you. I'll tell you. This is a case where you have a right communicating endometrial lining, up to the fundus. When I take transverse sweep, you were able to appreciate another cavitatory lesion onto the left side. I will try to show that now. Then when I go towards the left, I want to be slow because we might miss these cases. So on to the left, you are able to see another endometrial lining like thing with a cavitatory lesion inside with some blood inside. This is low intensity echo, but the serosal lining, it's maintaining its integrity. Whereas in unicornate with non-communicating or communicating, you would see two well-defined horns, one side separate and another separate. But this is well within the serosal lining. This serosal lining is maintaining integrity, whereas this cavitatory lesion was not communicating to the rest of the uterus. So this is what we get as sometimes. This is what we get. This is a case of Robert's uterus. So here Roberts is a case of subtype of septate variety where you have a non-communicating horn, and you have a communicating horn. You have a septa up to one lateral border of the uterus, but you have only one cervical communication. There are 3 types of Roberts uterus. If this endometrial lining was very active, then in very early phase after menarche, there would have been a very good large hematometra, and that needs evacuation by cutting this septa, where we need a unification surgery. That there are 3 types of Robert's uterus. So this is how we put it in our diagram. It was atretic here. It was atretic, so she was not having so much of pain. It was non-functional cavity. So yes, what is that? This is actually my retrospective learning. When sir did the hysteroscope, he saw only, I had given the diagnosis as uniconjugate with non-communicating horn. Yeah. But this is what we saw. There was only one cavitatory lesion, but only after when we went laparoscopically, we could see the uterine morphology was normal. So you can see, appreciate in hysteroscope, there was only right communicating horn. I will just show that. So it was there was a blind cavity on this side onto the left side of the uterus. So it was only after going the sorry. So only after going in the laparoscopy, you can able to appreciate the uterus having a normal fundal counter. So it was not a non-communicating or a unicornate uterus. So this is how we did analyze that it was a case of Robert's uterus, and this was a non-communicating part. This was the communicating part. So we had to give cuts in the hysteroscope and unify that. So we had to give cuts onto that, though there was no functional endometrial lining in that. So ASRM now has come up with this entity of Robert's uterus. There you can appreciate that non-communicating. It is well within one uterine on uterine serosal borders. So it's a case of Robert's uterus. You have 3 types now with the hematometra, with or without hematometra. So this is another case.
With the ultrasound, that was a transabdominal sonography. In this,
a young girl of 19 years presented with history of progressive and severe dysmenorrhea. On transabdominal sonography, I was able to appreciate this cavitatory lesion well within the myometrial mantle or the myometrial echoes. This was non-communicating to that of the endometrial lining. If you see closely, the cavitatory lesion was showing low intensity echoes that you see in an endometrioma. Whereas I took my probe onto the fundus, I could see the endometrium lining was getting splayed across. That means to say the triangular shaped endometrial lining to one horn, one cornal region to other cornal region was in uniform pattern. This lesion was more anterior onto the near to the adnexa. So here this cavitatory lesion, so you can see appreciate the triangular shaped endometrial cavitatory lesion, and you can appreciate this was a diagrammatic representation that we give, and we told this as ACU. So accessory cavitatory uterine malformation. So you can appreciate that this is a Mullerian anomaly usually presented in young girls who present with severe and progressive dysmenorrhea. Many of us diagnose this case of a degenerative fibroid or sometimes an adenomyoma. Laparoscopy sometimes will be negative unless and until you tell them that it is a cavitatory lesion there. And if you have mapped that few simple cuts on that particular lesion after we have instilled the vasopressin, you can appreciate that this cavitatory lesion was adenomyotic kind of lesion, and the histopathology also proved when we removed this. This is the treatment for such case. This is it. You have to excise this cavitatory lesion and resuture the bed. That's the treatment for such cases. Fertility issues are not much in such cases. Severe and progressive dysmenorrhea is what they present with. So this is all some few ACUMs that 3D we have. So this is all about a few cases of Mullerian anomalies I wanted to share about. Thank you so much, sir, for the opportunity.
Thank you so much, Dr. Raju, sir.
Thank
It was
you.
a wonderful presentation, and I think more than the presentation, your imaging skills are excellent, and all the images were too good. I think if it was only a theory class, you wouldn't have enjoyed it this much. And especially the intra-op correlation helped us understand our ultrasound images much more better, and what is the next step we could be going if we diagnose a Mullerian anomaly. All these questions were answered, and
Yes.
I think it's a wonderful presentation. Thank you so much. And such an in-depth, I think I have not heard such an in-depth talk on Mullerian anomaly. It was excellent.
Thank you so much, ma'am. Thank you, ma'am.
Thank you so much, sir, for presenting today. I think the chat box was how to differentiate between Robert's uterus and ACUM.
Okay, can I share my 1 second?
I think you can share that. You're the host.
Okay. Are you able to appreciate this screen, ma'am?
Yes, sir. It's not full screen, but yeah, we can see. Yeah.
Okay, this will be a normal uterus. Okay, this will be a normal uterus. The question is between ACUM and Robert's uterus, right?
Yes.
Okay, in Robert's uterus, we usually find communicating one side of the uterine horn, and the serosal layer will be having this kind of entity. But whereas you will have a non-communicating endometrial lining which is communicating to the fallopian tubes, if at all, and this will be communicating to this. This can be with hematometra or without hematometra. In our case, it was atretic. That is one theory to share that after some times the endometrial glands, if they are not functioning, will go for atresia. So this is a non-communicating horn. This is a non-communicating horn well within the uterine cavity. So now how do you differentiate this with ACUM? It's a very good question. Why? Because this patient also, if it is in an early young age after menarche, they will present with progressive and severe dysmenorrhea. If at all this is active endometrial lining, they will have a huge hematometra here. Okay, but what is the clinch in the diagnosis here? You don't find the endometrial lining getting its triangular shape. I mean to get this shape of endometrial lining, you will not be able to get in that case. What happens in ACUM? ACUM is the same variety, but here you can see, appreciate this. You have a triangular shaped endometrial lining, and this lesion usually is anterior and to near the round ligament attachment. They say it is because of some defect in the gubernaculum pathology, where you have this cavitatory lesion. This lesion is surrounded by some smooth muscles, whereas the inner layer is having the endometrial lining. This endometrial lining sometimes shreds with the physiology, and you have this hematometra inside. What is the differential diagnosis? Is that this is the clue. This is the clue where you have a triangular shaped normal morphology of the uterine fundus or the corpus, whereas in septate with the Robert's uterus entity, you don't find that. You find as if it is a unicornate uterus, but when it is within the normal serosal or a serosal counter, then it differentiate. Now again, and somebody would ask me how to differentiate this with unicornate with non-communicating. This would be the answer for them. You have a separate entity here, and you have this non-communicating horn well separate from that. So here also you have an endometrial lining. These people also will be shredding, will be having the cavitatory reaction inside, and they also present with severe dysmenorrhea, but it is non-communicating. I hope this makes the answer clear for them.
Yes, sir. Perfect answer. I think we have to look at the serocell surface, the shape of the
Yes.
endometrial cavity, and then
Yes, ma'am. That is why I played my third clip often and often. The reason is we only keep looking at the separation of the endometrial linings, but we forget to look at the serosal counter line. If that is maintaining its integrity when you're taking your 2D sweeps, then I don't think you need to really do a 3D for a subseptate uterus. Yes, you know that it is a case of subseptate uterus. Thank you.
yes, sir. I think 2D along with 3D adds a lot of information as to what type of Mullerian anomaly it is, and both are complementary, so we do not skip any of that.
Yes, ma'am.
It was an excellent presentation, sir. Thank you so much. I think there are no more questions, so we'll wind off today's session. Thank you everyone for joining us in and spending your time here. Hope all are benefited. Thank you. Till next
Thank you.
session.
Thank you so much, ma'am. Thank you. Thank you, sir.